Tom Murtaugh of the Christ Hospital in Cincinnati, Ohio, on behalf of the International Cardio-Oncology Society with highlights of a recent webinar. In this highlight, we hear from Dr. Prince Otchere on the topic of cardiac risk prediction models for patients with HER2-positive breast cancers. Dr. Otchere is currently assistant professor at the University of Texas in San Antonio, where he co-directs the Cardio-Oncology Clinic. He also collaborates with professionals in Ghana, working to establish cardio-oncology services in that country as well. Please enjoy Dr. Otchere's presentation on this important topic.
So let's get into the presentation. So we know that an estimated 25% of all breast cancer patients have HER2 overexpression. And we also know that HER2 positive HER2 inhibitors are currently what we are using, and trastuzumab by far is the most common inhibitor that we are using. Other inhibitors that are also being used, lapatinib, pertuzumab, are all being in use, and they have similar mechanism of action. We know that trastuzumab can cause a decrease in LV decline, but it's very interesting that in the literature, it says 13%, 3% to 19% is the range of LV decline, which is really a wide range when you think about it. And we will talk about why that is the case. Symptomatic heart failure, however, is less than LV decline. So one approach to prevent cardiotoxicity is to prevent risk. And in so doing, we can actually mitigate the risk. And to do that, you need models to be able to that patients and their oncologists can be able to use. Currently, there is no widely accepted clinical cardiac risk prediction model that are developed with statistical and epidemiologic tools that are widely accepted. The good thing is that we have some that are in the guidelines, ICOS guidelines and ESC guidelines that are done mostly with just people who have been doing it for a long time and have guided us to create certain models. But when we are talking about clinical and risk prediction tools that are rigorously and statistically done, there isn't one that is in use right now. The first risk prediction tool that really showed promise was this paper that was published in the Journal of American Heart Association, and they did a great job with this model. It was done with 1,664 women, but the age was restrictive. The age that they used for this model was 67 and 94-year-olds. And also it was administrative database in CM Medicare database. And we know the limitations that comes with using a clinical database in research work. They are important, but they have significant limitations. The candidate predictors that they used for that was heart failure, cardiomyopathy, age, race, CAD, atrial fibrillation, renal disease, and they obtained this from ICD codes. And so for patients with heart failure, we did a lot of times we don't even know what the EF is. We don't know what type of heart failure it is. We don't know what modality what was used. Was it an echo that was used to define heart failure? Was it a MAGA? Or was it just clinical diagnosis? So those are some of the things that makes it difficult to use a database like that. They use a split sample design, so they basically divided their population into two, one for the derivative cohort, one for the validation cohort. They use cost proportional hazard model, pretty standard. And in the validation data set, they use the chi-squared for, and then they use the osmolar lemma for the calibration as well. And the outcome was heart failure or cardiomyopathy within 3 years after diagnosis. And that's what I explained. It's not, we're using the ICD code. It was not really easy to tell what that means. So this is some of the data that from table 1 from that data. So as you can see with their calibration was pretty good. It was very good. So we could actually tell that with the higher risk factors, heart failure and cardiomyopathy increased. And so it did show promise. It was a very promising study. This is a discussion from that paper. Basically, they did a great job in stating the limitations of that paper, and they mentioned that because of administrative database, heart failure and cardiomyopathy could not be verified. The amount of EF decline could also not be verified, and the modality of assessment could not be obtained as well. But it definitely was, and I agree with them, was a good proof of concept for future clinically derived risk models. So that brings us to the aim of our study. So our aim was to create a cardiac risk prediction model among women with a varying age. Theirs was more on the older population, but us, we wanted to a risk prediction that could be used in a wider age group, so 18 and above. And basically, our outcome assessment was LVEF declined by 10% to less than 53% in a 1-year period, using data from health records where we could actually assess EF, LVEF. So we collected the data from 2 health systems. There were about 10 hospitals in these health systems. And so we had about 477 when we combined from the 2 different health systems. So Karen Health Network in Ohio and Premier Health Work. And we really appreciate of us using their data as well. So we included, like I said, 8 women who were 18 years or older, who had been on trastuzumab from 2015 and 2019. And patients should have had an echo at baseline, and they should also have an echo at a period after that, hopefully 12 months. And if they didn't have any echo, they were on trastuzumab, but they didn't have echo, we had to exclude them. We did decide that if somebody doesn't have an echo at 12 months, but they had an echo at 9 months and 6 months, we were going to include them in our study. So that's what we did. And after we did that, we were able to use 415 patients. That was our end number. And again, our outcome measure was defined as a drop in LVEF by more than 10% to 53% in a 1-year period. So a very clearly defined outcome. In construction of our variables, we use predictors that were known in the literature and also from the previous risk prediction models. So we use age, race, obesity, history of coronary disease, history of prior radiation use, concurrent adriamycin use, radiation therapy, diabetes, hypertension, and renal disease. These were all tested in our derivative models. So we also use a split sample design, basically taking the big population and splitting them into 2, and using one for our derivation model and using the second one for our validation model. So the derivation cohort was 65% of we are going to use 65% of the study population, and the validation was going to be 35%. And we use logistic regression for the derivation model. For the validation model, we use the ROC to determine the area under the curve, and confusion metrics to determine the performance of the model. Statistics was done in R. The study was approved was approved by the RV of individual health systems. So going to the results, we can see it's a bit busy slide, but the table for the baseline characteristics. We can see that the age at diagnosis here was 58, and different from the previous model, which had a higher higher age. The baseline EF was 62%, and we can see the other prevailing disease and also things that happen after, like incident heart failure as well, and in this table. So the cumulative incidence of the cardiac dysfunction in the overall cohort was 9.4%. And then looking at like we said before, we used 65% of the data for the derivation cohort, and that was 270 participants or patients, and then 35%, which is 145, was used for the validation. So in our derivation cohort, the incident cardiac dysfunction was 9.3%, very close to when we take the overall cohort, that was 9.4, and then the derivation cohort, the incident cardiac dysfunction was 9.3. So you see some precision here compared to in the literature when we use administrative database. There's just a really wide gap. So this is our derivative model. And so one thing is, and I'll talk a little more about that, with our derivative model, we try to, of course, include all the known risk factors. But as you can see, we did not use all of them because we have a smaller sample, and with risk prediction, with a smaller sample, it becomes a little unstable, and you may overfit the model. So age, stroke, diabetes, and Adriamycin were the ones that were used. Interestingly, when we use interaction terms between Adriamycin and diabetes, stroke, and Adriamycin, age at diagnosis and diabetes, those interaction or effect modification improved our model as well. And so this is for the validation for the area under the care for discrimination. Our AUC was 64%, and in all fairness, it's modest. It's a really a modest discrimination, not what, and it could definitely be improved upon, but this is what we have with our validation. And for the test performance using confusion metric, the sensitivity was low, but the specificity was high, 94%. And as you know, this for primary prevention risk modeling, specificity is actually the most important. So it was modestly high specificity, 94%. The negative predictive value here was 94%, and that's also an important thing that we need to talk about. So for the discussion, so the cumulative incidence of LV decline was 9.4% in the general cohort. And then the cumulative incidence of LV decline in the derivation cohort was 9.3. Very good approximation. But in the literature, it was actually from 4 to 19%. There's a typo here, 4 to 19%. And that tells you that with using administrative database, because outcomes are not always well explained, and it's not always well easy to understand how they are being put into the database, it can vary so much. So the difference that I think is really by having a good outcome definition. And it's also important because when you are developing a risk prediction model, eventually you want it to get into the hands of a clinician, and that clinician should be able to have like a very easy way to tell, this is the patient that, this is the outcome that I'm looking for, and this is how I can actually use it in my population. So in a derivation cohort, again, adriamycin, diabetes, and stroke increase the risk, and we know that, and it has been shown time and time again. The model, like I said, had low sensitivity but high specificity, which is important for risk prediction, primary risk prediction. And so the model, it modestly performs well. And so, but the negative predictive value was 95%. So the probability of not experiencing LV decline in 12 months, giving a negative test, not echo, a negative test, is 94%. And that is very important because if we are able to enhance upon this model and create a calculator, and we're able to put it into a calculator, if our model says that you are low risk, there's a very low likelihood that in 12 months you are going to get at any LV decline, not to talk about heart failure symptoms. And so that brings to the point, it really emphasizes the point of, in low risk patients, should we be getting echo every 3 months? And this paper challenges that notion that in very low risk patients, the likelihood of LV decline is really low. And so should we be doing every 3 months? And so as we know, with the FDA mandate of every 3 months, what is the real big, strong data behind it? And I think one of the work that is being done, I think by you, is that is currently ongoing, is assessing if we have a baseline and we have an echo at 6 months and then at 12 months, are we still going to be able to, is it still going to be safe, but at the same time, going to be not different from doing echo every 3 months? So we look forward to that paper. So again, in high risk, and we want to be able to say that in a low risk patient, we think that we can probably screen them less frequently, probably every 6 months. But in high risk patients with a good risk prediction model, we probably can stay at 3 months as well. And this is actually safe. And as we know with our patients, I mean, they are going to see a radiation oncologist, they are seeing a surgical oncologist, they are seeing that. So, excessive testing is actually not what we want to do. So we want to have a risk prediction tool that assesses risk, but it's also helpful for patients not to be overburdened as well. So again, and I have mentioned this, that future studies really should be using a well-defined outcome, and as we have done, because it really takes away a lot of the miscoding and inadequate coding of heart failure that sometimes happens, and reduce the ambiguity in outcome definition, and adds the accuracy and reliability of our outcome measures and also our risk prediction model. Again, it's small sample size. The problem with using the advantage of using a CM Medicare database is a huge population, and so it's really great when you have that, because your model can handle many predictors in the derivation model. It does not. It reduces the problem of unfitted models, and your model become unstable. But then you have to address the fact that what is my outcome? But in what we also are doing here, with using precise LV, you really need you really need to be able to get clinic level data that is large enough. And it's very challenging and very interesting that when I was building this, I was looking for other institutions that had this kind of data, LVEF decline for trastuzumab, and there were not many people who had this data. So that is something that we want to work on, but I think other people really need to work on as well, so that we can have bigger cohorts for the future as well. So, and my patient was mostly, white. And so when you build a risk model that is going to be used by diverse population, that's something that we would like to work on in the future in refining our model. And because it does affect generalizability. Okay. And then there were some people that had baseline echo and didn't have like a 12-month echo, or like had a 6-month echo and 9-month echo, didn't have 12-month echo. And that's something that we would like also to improve on and can affect what if they went all the way to the 12 months. Again, thinking counterfactual, would that have been able to decrease? I mean, will something have happened at that time? Again, I think we really need to work on risk prediction in our space to be able to predict risk for the low risk patients, but also for the high risk patient, so that we can better able to personalize what we are doing. And currently, there isn't great information in this population, and so I think this paper shows that there's definitely promise. We have in a high specificity and high negative predictive value. But we definitely need to do more by refining our model, adding more patients to this cohort, and coming up with being able to add more predictors. And at the same time, our model won't be unstable and we won't overfit the model. And if we get that, we will to have a good AUC and calibrate it well and be able to bring it into clinical use. Thank you so much for your time and giving the opportunity to share the work that we are interested in doing and we've already been doing. Thank you so much, Steve.
Thanks to Dr. Otchere for showing us a path forward in this important and challenging area. Don't forget to check out the ICOS website at ic-os.org. And if you've not done it already, consider making plans to be at the GCOS Summit this September in Minneapolis, Minnesota. Details are available at the website. Until the next highlight, ICOS reminds you to treat cancer, protect hearts.